everyone, I'm going to be presenting on a topic that I find extremely interesting with the field that I'm going into in cardiac rehab. We also deal with a lot of people with COPD. So I wanted to touch on this topic because I know I'm going to be working with a lot of people with this very tough disease as well. So my topic is the effects of exercise on cardiovascular and pulmonary function in individuals with chronic obstructive pulmonary disorder, most commonly known as COPD. So, what is COPD and why is it a problem? COPD is a progressive respiratory condition that is caused by inflammation that limits airflow to the lungs. It is primarily due to inflammation triggered by long-term pollutants such as smoking or secondhand smoke, or it can also be due to occupational pollutants as well and environmental pollutants. COPD affects nearly 16 million Americans and is one of the leading causes of death in the United States and also in the world as well. Unfortunately, there is no cure, but it can be managed by pulmonary rehabilitation. Because COPD damages the lungs, causing inflammation, it makes it very difficult to breathe. This reduced oxygen stress leads to conditions such as pulmonary hypertension or heart failure. So it can be causing a domino effect affecting other organs as well. I thought this was a fun little image here that I found from the Everyday Health website. It shows everything that pulmonary rehabilitation helps you to do. So it helps you breathe easier, increase exercise tolerance, improves mood, overall quality of life, and helps you stay out of the hospital. So that's going to be my main focus with this topic today. So what is the purpose of this study? I wanted to highlight the correlation between pulmonary rehabilitation, overall quality of life, reduced hospital visits, reduced breathlessness, and so many other things. So I created a graph here, the reduction in healthcare utilization before and after pulmonary rehabilitation. So hospital admissions from before to after pulmonary rehabilitation, it went down 48.2%. That's huge. The length of stay also in the hospital is down 46.6%, and exacerbations like flare-ups went down 42.5%. So those are all really huge numbers. And the study will show how pulmonary rehabilitation reduces symptoms and lowers the rates of hospitalization and decreases dyspnea. Unfortunately, with each study, there are limitations, but it is very important to see how you are able to handle those obstacles. So, what are the limitations of this study? Potential limitations with the rehabilitation include being subjective to exercise. That's a big one, especially people with disease. They can be very subjective and often underestimate what they can do or overestimate as well. There can be a major lack of intrinsic motivation, so that motivation within, the lack of promotion of health behavior change, comorbidities such as heart disease, and the tolerance of exercise is very subjective to those with disease. And also a big one I wanted to touch on is medications such as beta blockers, and specifically beta blockers that can affect your heart rate during a working rate, because beta blockers work with the heart to make it not raise so much while you're doing any sort of exercise. So it makes it hard to really understand if a person is at a high enough working rate when their heart rate is not jumping up as much. So it's really important to find out medications that someone is on prior to the study. So, with the limitations comes the delimitations. So, it's all about how you handle the limitations within the study and be able to limit them as much as possible. So, the delimitations include using the Borg scale, and I'm going to show that on the next slide there. So, that's a scale of breathlessness. Basically, it's a scale from 1 to 10, from 0 to 10, 0 meaning no problem at all, 10 being I can't breathe. Also checking the pulse and the blood pressure throughout to be less subjective with exercise as well, not just relying on heart rate for working rate. A second delimitation for lack of motivation as well as health behavior change is to set up educational plans in advance for each person, helping them understand their why and how this is going to help them out in the short and the long term. And then, kind of like how I touched on the last slide, understanding medications and asking on the informed consent any medications such as beta blockers to understand what implications that can have on exercise. And once again, I'm touching on the beta blockers because that is a huge proponent to the working rate with the heart rate, and it can really affect a lot. So it's always good to check different things as well, such as blood pressure, and using the Borg scale. Kind of using all of them in conjunction with each other is very helpful instead of just relying on one thing. So I wanted to create a visual and help everyone understand the Borg scale a little bit better. So this is the Borg scale for dyspnea, the breathlessness scale. So this is what a physician or an exercise physiologist would ask the patient to point to throughout the exercise. So it starts at 0, so no breathlessness at all, to a slight breathlessness, very slight, moderate, somewhat severe, very severe, and 10, like you can't breathe at all. So it is important to use this. So it's a very good tool for them to really just be able to point at during their exercise. Makes it very, very easy to understand. The hypothesis of this study shows there's a very strong correlation with those who attend rehabilitation programs and lower hospitalization visits and a higher quality of life versus those who do not attend the programs. Those who participate in cardiac and pulmonary rehabilitation programs have significantly lower major pulmonary or cardiac events in the future versus those who do not, specifically ones that attend 8 or more weeks of a specifically designed program for that person, such as pulmonary or cardiac rehab. I want to share with you a literature review that I have found through many really amazing studies that really prove the point that I was trying to drive home about how important rehabilitation is. So, I wanted to touch on how COPD is a disease that not only affects the lungs, but it also affects the heart as well. It leads to systemic deconditioning and secondary cardiovascular strain. So it can create a domino effect, which is very unfortunate. A lower ratio of forced expiratory volume, which is the amount that you breathe out in your first second of the forced breathing, to forced vital capacity is also an independent predictor of coronary events. This increases the risk by roughly 30%. And additionally, for every 10% drop in that, there is a 14% increase in all-cause mortality and a 28% rise in cardiovascular mortality. So rehabilitation aims to reverse these effects through structured exercise, breathing retraining, such as pursed lip breathing and diaphragmatic breathing, and formal education on the topic. Pulmonary rehabilitation leads to an increase in exercise tolerance, decreased dyspnea, and as well as overall improved quality of life, resulting in lesser hospital visits. Rehabilitation programs are crucial for all stages of COPD, not just severe and not just moderate. The three main objectives to focus on with COPD are VO2 max, cardiac output, and vascular function. Exercise is proven to be great therapy for pulmonary disorders. The programs focus very heavily on education, exercise, breathing retraining, and mental health support. There is a huge depressed and anxious population within the COPD community, so it's also very important to touch on the mental health aspect in the education as well. So that's why I wanted to add that in there. Before and after the programs, symptoms, oxygen needs, exercise capacity, medical history, comorbidities, and everything are gathered to understand the patient better. Individuals with COPD are also twice as likely to suffer from heart complications than the general population, which is very scary because they're already dealing with such bad pulmonary disorders. Now they're dealing with cardiovascular complications. And even though with COPD patients, they have an impaired exercise capacity, the core principles of rehabilitation should be based on the core principles of exercise physiology. The initial training load should match the requirements and health status of that specific patient, but also exceed the demands encountered in activities of daily living. And with individuals with COPD, you may need to start off extremely light. With some people, they can't even walk to the mailbox and back, so starting with bouts of 5 to 10 minutes might be needed at the beginning and then can be increased throughout the program. I found a really amazing study that I wanted to use as a great example of this study background. So the whole premise was there was 26 individuals with COPD who demonstrated normal exercise capacity. They were recruited from an outpatient clinic for this study. And this was in 2009 to 2013. So there was years of this put together. The participants met the following inclusion criteria: a confirmed diagnosis of COPD, normal exercise capacity, clinical stability without flare-ups, no increased use of rescue inhalers or corticosteroids, no scheduled medical visits related to COPD in the last 3 months, and the ability to move independently because they need to exercise for this program. The exclusion criteria included the use of oral corticosteroids, a history of other pulmonary diseases, as well as orthopedic, neurological, or cardiovascular conditions that could prevent them from participating in the exercise program. So how was this study done exactly? The study was measured by evaluating spirometry and respiratory muscle strength testing. The cardiopulmonary exercise test was included on an incremental exercise test on a cycle ergometer before and after rehabilitation. This was a 12-week program, 2 sessions per week, which was focused on formal education, breathing retraining, proper use of medication, self-management skills, and exercise, and they were all given individually. After the education, the exercise training with the cycle ergometer was given. Exercise sessions were 40 minutes and the intensity targets were pretty high, which were 75 to 100% of their VO2. So this was tested, what their VO2 was tested prior to the rehabilitation. So that's how they knew where to get between 75 to 100%. Work rate, oxygen saturation, heart rate, dyspnea scores, and leg fatigue were monitored during every exercise training session. which included measurements of maximal inspiratory and maximal expiratory pressure, and cardiopulmonary exercise were tested before and after each session. The results of the study show an improvement on so many things, so I wanted to touch on that. And they were all broken down into different categories to make it really easy to understand. So, changes in quality of life show a significant improvement, such as symptoms, activity, impact, and overall quality of life. There were a significant improvements in all of those domains. Changes in lung function had small improvement in pulmonary function test results. However, respiratory muscle strength significantly improved over the 12 weeks. Ventilation, heart rate, and blood pressure remained unchanged. However, the maximum oxygen pulse during exercise increased significantly, and the average dyspnea scores at the end went from 5.7 before rehab to 4.8. This is approaching levels seen in healthy individuals like you and I. So here's a cool little visual that I created. So you can see the peak VO2 here on the left and the dyspnea scores on the right. So you can see in the yellow, this is before rehabilitation, the peak value of VO2 increased by so much after rehab, and the dyspnea score decreased by a good amount as well. It doesn't look like it's as much compared to the peak VO2, but its values are a lot closer in general. But like I touched on in the last slide, it approached levels on average to healthy individuals, which is amazing. The independent study that I wanted to conduct was the effect of an 8-week supervised pulmonary rehabilitation program versus those who did not attend pulmonary rehab. They just got the usual care from the hospital, no exercise, nothing. They just got an educational pamphlet and pretty much were sent off. So they have moderate to severe COPD according to the GOLD stage. They've been stable in their disease for at least 4 weeks with no exacerbations or flare-ups, no requiring steroids, no hospitalizations within the last 4 weeks, and are able to walk because I need them to attend the exercise testing. The baseline fitness will be calculated by the 6-minute walk test following the American Thoracic Society guidelines, and I cited that. Dyspnea will be monitored while using the Borg scale. Remember that I touched on a couple slides ago. The quality of life questionnaire will be filled out, and muscle strength tests will be done with a sit to stand before and after rehabilitation. And this will be split up 1-to-1. So 50% will be in the pulmonary rehabilitation program, and the other 50% are just getting the usual hospital care, educational pamphlet, and sent on their way. So my goal is to see how much pulmonary rehabilitation really helps people with COPD. So how will this be done? So the pulmonary rehabilitation group will attend supervised exercise sessions, and this will be at least 60 minutes. The exercises include walking or cycling, and this is going to be at 60% of the peak work rate and progressing as tolerated. Strength training will include upper and lower limb exercises with weights or resistance bands. This is going to be 2 to 3 sets of 10 to 15 repetitions. Education modules will be included by teaching them about medication use, airway clearance, energy conservation, nutrition, breathing retraining, coping strategies, mental health support, etc. Oxygen saturation and heart rate will be monitored, and adverse effects will be documented. So as I touched on a couple slides ago, so the usual care group will be the control group. They will continue standard medical care. Basically, they get sent home with an education pamphlet and they go on their way. The purpose of this study is to see the overall difference and the benefit of pulmonary rehab versus basic usual care that people get. The assessments will occur at baseline, 8 weeks, and 6 months post-intervention. So this includes 1, quality of life, 2, dyspnea severity, 3, muscle strength, and 4, frequency of exacerbations and hospitalizations. So here I have a little chart. So there's the data collection with pulmonary rehab before, control group before, after for both as well, and then you can see the boxes. So that would be the quality of life for each section before and after, dyspnea score, strength, and frequency of hospitalizations and exacerbations. So that all would be compared. The findings of this study, the primary outcome is the change in the 6-minute walk test from baseline to 8 weeks. And then the secondary outcomes are measured by the dyspnea scores, quality of life, muscle strength, and hospitalizations, like the chart I showed you on the last slide. By comparing the two, the study aims to measure the meaningful changes in outcomes, such as the 6-minute walk test, dyspnea scores, and quality of life. So it's just comparing the two and showing how much pulmonary rehabilitation truly helps people with COPD. In conclusion, this trial is designed to evaluate the effectiveness of an 8-week rehabilitation program in improving exercise capacity and quality of life for those who suffer from moderate to severe COPD. This research will contribute to optimizing rehabilitation strategies, improving outcomes, and having a deeper understanding on what works for those diagnosed with COPDs and other comorbidities such as heart disease. These findings are expected to strengthen the evidence as a foundation of COPD care. I just want to thank you all for listening, and I also wanted to show you my references here. So I have a laundry list of references, as you can see. I have the first page here, and then I have another page, and this bottom reference, the benefits of pulmonary rehabilitation one, that one helped me so much throughout this process, really helped me push my point home. So thank you again for listening.